Today we're going to talk about how to assess for uncovertebral joint restriction in the cervical spine and then how to treat it. So if you look back at our old videos, we talk about assessing the mid to lower cervical spine just using mini side glides, working your way up and down the neck, just pushing the vertebra side to side, which kind of simulates side bending at that joint and looking for restriction. Because of the joint alignment of the facets, when you side bend towards one side, you're extending on those facets and flexing on the opposite side. So that's kind of how you can assess both flexion and extension restrictions in the mid-cervical spine. And to figure out which one is restricted, you move into either extension to bias one way or flexion to bias the other. Now, what can be an issue is if someone has a restriction in those uncovertebral joints, which is located between the vertebral bodies. The way the patient will present typically is they have maybe mildly restricted flexion, extension, and rotation, but then when you look at side bending, there's a significant loss. And this is one of the first areas where you see degeneration take place. If a patient presents with that, checking these side glides aren't going to be quite as useful for differentiating facet versus uncovertebral joint restriction. You can still use it to look for the uncovertebral joints. However, you want to also check the facets, and the way you do that is you just do a flexion glide on each segment to see if it's hypomobile or moving well. So if you, for example, say you find at C4 when you push to the left that it's restricted, but then you check flexion and extension on each side and it feels like it's moving well there, then that can tell you that the restriction is with the uncovertebral joint. So how do we treat that? There's a couple different methods manipulation-wise. You can use some METs. I prefer to just use manipulation as it's faster. The first one, I don't use at all. It's the way that I was taught first, but I find it just uncomfortable. I'll still show you. You're going to, go ahead and come around, Sam. Scoot this way, maybe. So you're going to hold the head in that football hold, kind of like you would for the OA mobilization manipulation. And then you're going to apply pressure with your second MCP right on the articular pillar. So I have my hand there now, but I'm going to kind of come around and show you what it looks like there. So right here is pressing on the articular pillar. And if it were the OA joint, you're going to be applying a distraction that way. And as you move down each vertebra, you're going to kind of shift your angle. So if I'm at like C5 or 6, I'm going to be mobilizing that way. Now, like I said, I don't like this one. I feel it's uncomfortable. The way that I find is easier is, say we're restricted here. One other thing I want to point out is that depending on who you talk to, if you're restricted with a side glide that way, some will tell you want to manipulate the same segment the opposite way. I found some patients respond better doing it that, and some respond doing the other. Regardless, the technique is the same. You can use a pincer grasp right on the transverse process and do a little bit of a side bend with your other hand to kind of take up some slack while you provide a translational force. And so you take up the slack there. Ask the patient how they feel. Does that feel okay?
Feels great.
Okay. And then it's just a quick little thrust. You may hear a pop, you may not. It's not necessary, but then you'll just recheck the mobility afterwards, side glides, to see if it's changed. Also, you can recheck the patient's active motion to see if it changed as well. So the way it looks like, full speed, take up the slack, just like that. Nice little small push. Okay.